This is the Neurological Chronic Conditions lecture covering the different types of seizures. A seizure is a paroxysmal, uncontrolled electrical discharge of neurons in the brain that interrupts the brain's normal function. Epilepsy is a condition in which a person has spontaneous recurring seizures that's usually caused by an underlying condition. Conditions that lead to epilepsy can vary depending on the age in which the individual began to experience the seizure activity. Epilepsy diagnosed in individuals under 6 months of age usually see it as a result of a severe birth injury or possibly a congenital birth defect involving the central nervous system. In children and adolescents, we can see epilepsy occur as a result of an infection that they may have encountered, a traumatic injury, and possibly even genetic factors. Young adults between the ages of 20 and 30 oftentimes can develop epilepsy as a result of structural lesions, also trauma, possibly a brain tumor, or even vascular disease. The most common causes that we see for epilepsy to develop in individuals over age 50 are due to a stroke or metastatic brain tumors. However, even with multiple potential underlying conditions that cause epilepsy to develop, still approximately 30% of all cases of epilepsy are idiopathic, so meaning we do not have an accountable chronic underlying condition in which to relate the diagnosis of epilepsy to. There are more than 200,000 new cases of epilepsy diagnosed in the United States each year. New cases are more common in African Americans and in men. We also see it develop more frequently in individuals with Alzheimer's disease and in individuals who've had a stroke. There is also an increased risk in a person who has a parent who has had epilepsy. Seizures are divided into two major classes. We have generalized seizures and focal seizures. The generalized seizures involve both sides of the brain at onset. Focal seizures begin in one hemisphere of the brain, and they can be indicated as to which particular area of the brain is affected on an EEG. Focal seizures have unilateral manifestations, which involves a particular function, a sensory, motor, cognitive, or emotional symptom. And these manifestations can vary greatly depending on, again, that particular area of the brain in which the seizure occurs. There are two types of generalized seizures. We refer to them as tonic-clonic seizures and as absent seizures. And then with absent seizures, we even subdivide them into typical and atypical. We'll discuss the absent seizures on the next slide, but here we're going to look at the first type of generalized seizure, which is the tonic-clonic seizure. This is the most common type of seizures. It used to be referred to as what was known as the grand mal seizure. Tonic-clonic seizures are characterized by a patient losing consciousness. If they're not in a supine position already, they will fall. They will then go through first a tonic phase where the body stiffens. This usually lasts about 10 to 20 seconds. It will then be followed by what we call the clonic phase, where the patient begins subsequent jerking of the extremities, and this usually lasts another 30 to 40 seconds. Again, these are generalized seizures, so they're involving both sides of the brain from the onset of the seizure. During the tonic-clonic seizure, in addition to the loss of consciousness and the tonic and clonic phases of the seizure, the patient also may become cyanotic due to irregular or absent breathing. It's normal for them to excessively salivate. This can increase their risks for aspiration, and it's also possible that they bite their tongue or their cheek during the seizure, so it's not uncommon for us to see a little bit of blood coming from their mouth as well. There are multiple phases to the seizure activity. We refer to them as the prodromal phase, the oral phase, the ictal, and then the postictal phase. The prodromal phase is a phase that precedes the seizure with some type of sign or abnormal activity. The most common symptoms of the prodromal period can include things like confusion, anxiety, irritability, possibly headache, tremors, or anger, or other types of mood disturbances. The oral phase is thought of as a warning phase of an oncoming seizure. There's usually some type of abnormal sensory experience reported by the patient during the oral phase. This can be something such as vision loss or blurring. They may report flickering of their vision or hallucinations. It might be ringing or buzzing sounds in their ear. It could be a strange or offensive smell. It could be a bitter or acidic taste. It also could be something like numbness or tingling in different parts of the body. The aura for patients experiencing seizures can vary quite a bit from one individual to the next. The ictal phase is the phase in which the full seizure is actually occurring. The post-ictal phase is the period in which the patient then goes through a rest and recovery following the seizure. During the post-ictal phase, it's normal for the patient to sleep several hours, and it's also normal for them to not feel quite right for several hours to several days. Also, we do expect that they'll have no memory of the seizure activity itself. There's a video showing a client with a tonic-clonic seizure under your learning resources, what a tonic-clonic seizure looks like and what to do. I want you to review that video in preparation for class. The other type of generalized seizure is known as the absence seizure. There are two different types of absence seizures. These are the typical and the atypical absence seizure. Absence seizures are formally known as petit mal seizures. These types of seizures generally occur most often in children and are rare beyond adolescence. They may cease as the child matures, or it's often possible that they can develop into another type of seizures. These seizures usually do not have any aura or post-ictal symptoms after them. With the typical seizure, the typical symptom is a staring spell or daydreaming or blanking out. Typical absence seizures generally last for about 10 to 30 seconds at a time. They often can go unnoticed, and they may occur up to 100 times a day if they are untreated. EEG patterns demonstrate unique patterns to this particular type of seizure. So these are easily identifiable with an EEG test. The atypical absence seizure, for the most part, resembles the typical absence seizure. The differences between the atypical and the typical are that the atypical seizure tends to begin more slowly and also tends to last a little longer. Atypical absence seizures can last up to a few minutes, and these also oftentimes include the patient slumping or falling down. Another difference with the atypical absence seizure is that the person may also feel confused for a short time following the seizure. There is a video under your learning resources of an absence seizure that you can observe. The other types of seizures are known as focal seizures. Focal seizures can either be simple partial seizures or they can be complex partial seizures. With the simple partial seizure, the person remains conscious. They experience unusual feelings or sensations that can take many forms. It can be a sudden and unexplainable feeling of joy, anger, sadness, or possibly nausea. They may actually hear, smell, taste, see, or feel things that are not real. Simple partial seizures tend to last about 30 seconds or less, and most of the time only last a few seconds at a time. The complex focal seizure or the complex partial seizure, the person has a change or a loss of consciousness with this one. Complex partial seizures produce a dreamlike state. And with these types of seizures, the individual tends to display strange behavior, such as lip smacking or what we call automatisms. Automatisms are repetitive movements that may not be appropriate. Some automatisms are organized, such as counting out change or picking up items off of a grocery shelf. Other automatisms can appear less organized. It could be picking at clothing or fumbling with objects. This can be real or imaginary. Some patients with complex partial seizures can also just simply start to walk away as part of the seizure behavior. Todd's paralysis is another symptom that we can see in association with the complex partial seizures. This is a neurological condition that in which the seizure is followed by a brief period of temporary paralysis. The paralysis can be partial or complete, but it usually just occurs on one side of the body, and it usually only lasts for about 1 to 2 minutes. Also, another note with the complex partial seizure is that the individual generally does not remember any activity that was started right before the seizure or any activity that occurred during the seizure. There are also going to be a couple of videos under the learning resources on Canvas that you can review to see the complex focal seizures or complex partial seizures taking place. And just to clarify, here on the slide, I have referred to them as simple partial seizure and complex partial seizure. They are also often referred to as a simple focal seizure or a complex focal seizure. So sometimes the words focal and partial are interchanged in the description of these types of seizures. Two other types of seizures that don't fit into the categories that we previously discussed are the psychogenic seizure and the febrile seizure. The psychogenic seizure is also sometimes called a pseudo-seizure. That was a former name for it. These are seizures that are psychiatric in origin. Patients do not experience any true loss of consciousness during the seizure. Patients with psychogenic seizures frequently have a history of emotional abuse, physical neglect, or some type of specific traumatic episode. Treatment with the psychogenic seizure depends on finding the root cause. What is triggering this particular type of seizure activity or this type of behavior? And so it's often going to consist of treatment more along the lines of psychiatric care, counseling, antidepressant therapy, and possibly antipsychotics. The other type, the febrile seizure, is a particular type of seizure that is known to occur in children between the ages of 6 months and 5 years. The greatest risk of the febrile seizure occurring is between the ages of 12 and 18 months old. Febrile seizures can be classified as either simple or complex. The simple type of febrile seizure is one that generally only lasts from a few seconds to no more than 15 minutes, and it does not recur within a 24-hour period, and it is not specific to one part of the body. The complex febrile seizures, on the other hand, typically last longer than 15 minutes and occur more than once in 24 hours, or they're often confined to just one particular side of the child's body. Febrile seizures occur most often within 24 hours of the onset of a fever and can sometimes be the first indication that a child is ill. Most febrile seizures produce no lasting effects for the child, and particularly the simple febrile seizures, which are the ones that we see most often. These do not cause any type of brain damage, intellectual disability, or learning disabilities, and they do not indicate a more serious underlying disorder. The most common complication with febrile seizures is the risk or the possibility of having more febrile seizures. The risk of recurrence is higher if the kid's first seizure was in relationship to a low fever, if the period between the start of the fever and the seizure was actually very short. If an immediate family member has a history of febrile seizures, they're going to be at higher risk for them. If they were younger than 18 months old the first time they experienced a febrile seizure, they're at increased risk for it happening again. For the most part, treatment with acetaminophen to bring down the temperature is effective in minimizing or preventing the risk of recurrence of a febrile seizure. However, in kids who are prone to long febrile seizures, they might recommend rectal diazepam or nasal midazolam to be prescribed for those children. But for the most part, we don't really use anticonvulsant therapy in the treatment of febrile seizures. We're only going to use those medications to treat seizures that are lasting longer than the 5 minutes, or if the child has more than one seizure in 24 hours. Bathing is even generally not usually recommended for preventing febrile seizures or lowering the body temperature, because the bathing will only lower the temperature as long as the child is in the bath. And usually shortly after coming out of the bath, the temperature will generally go right back to where it started. But if a bath is used, it needs to be a lukewarm or a tepid bath, one that's, again, closer to like normal body temperature. Anything cooler than that will cause shivering and can lead to a rebound temp in the child. Generally, the best thing to use to treat the fevers is really going to be removing the excess clothing on the child and utilizing antipyretics such as acetaminophen to bring the temperature down. Status epilepticus is a state of a constant seizure occurring without stopping, or a condition when seizures occur in rapid succession back to back without any return of consciousness of the individual between the seizures. It's one of the most serious complications that can occur in epileptics, and it is considered a neurological emergency when we observe this. It can happen with any type of seizure, so it's something that any patient with a history of seizure activity needs to be aware of as a potential complication. Status epilepticus causes the brain to use more energy than is supplied. The neurons become exhausted in status epilepticus and they cease to function. And without treatment and without stopping this type of seizure activity, permanent brain damage can result. So to treat status epilepticus, the best line of defense is going to be to utilize the group of drugs known as the benzodiazepines. Lorazepam, which is Ativan, or diazepam, which is Valium, also midazolam, which is Versed. These are going to be our first line treatment for this particular type of seizure activity to get control of the patient. Also, in order to stabilize the patient, the physician will often also go ahead with a loading dose of anticonvulsants such as phenytoin or levetiracetam, and they're going to generally administer those in a round-the-clock dosing format to build up an adequate blood level of that particular anticonvulsant to prevent status epilepticus from recurring in that individual. In regards to the treatment of seizures, we need to focus, one, on treating any underlying conditions that are known to cause the seizure activity. Accurate diagnosis of seizures is very important, and to do this, we need thorough descriptions of the seizure events when they take place, and we also need an accurate history taking of the individual. An EEG is going to be part of a diagnostic workup in someone with a seizure activity. They can expect to even have follow-up EEGs done throughout the course of the disease process. EEGs ideally should be done within 24 hours following seizure activity, but even then, a very small percentage of seizure activity actually even shows up the first time on an EEG. This can be problematic because some patients without seizure disorders can have abnormal EEGs, and some patients with seizures actually have normal EEGs. However, it is still our standard diagnostic tool for detecting the different types of seizure activity, that in conjunction with that accurate history and physical taking from the patient. As far as EEGs go, you can do anything from a 1-hour EEG up to about a 5-day EEG. They also have sleep and ambulatory EEGs that can be done in order to provide the best circumstances for obtaining any of that abnormal electrical activity that's occurring within the brain. If an individual is diagnosed with a seizure activity or epilepsy, one thing to note is that in most states, they have to be seizure-free anywhere from 6 to 12 months. That depends on the state's rules. If they are old enough to drive, they have to be seizure-free for 6 to 12 months before they get their license back. They'll have to have a note signed by a physician stating that they have been seizure-free for that state's required period of time before they would be eligible to be able to drive a vehicle again. Anticonvulsant therapy is obviously also something that we're going to include in part of the seizure treatment plan. There are several different types of anticonvulsants. It's best to review the Pharm Made Easy module, Neurological Part 1, that covers anticonvulsants. As part of this section's content, because anticonvulsants can be on your quiz. So make sure to take some time just to review at least that section before you come to the next quiz. Treatment generally for the generalized tonic-clonic seizures usually involve medications such as carbamazepine, Devalporex, gabapentin, lamotrigine, levetiracetam, or phenytoin. Those are meds often used in the treatment plan for the generalized tonic-clonic seizures. Absent seizures oftentimes are best treated with meds such as clonazepam. Devalporex is another one. Devalporex can be used for both absent seizures and generalized tonic-clonic seizures. And zonisamide is another one that's going to be utilized oftentimes for the absent seizures. Seizure precautions is definitely something that would be included in the collaborative care, so be very aware of what seizure precautions include. This would include making sure if a patient's placed on seizure precautions, we're going to need to make sure that the side rails of the bed are up and padded, that there is a suction machine readily available at the bedside, that we maintain the bed in a low locked position. If the patient does begin to have a seizure, we begin to quickly move objects away from the patient. We do not attempt to restrain the patient during the seizure activity. And we do, if possible, turn them to the side to prevent aspiration. If we're unable to turn them to the side during the seizure because it would put their safety at risk, then we would want to do that as immediately following the conclusion of the seizure, again, with the goal being to prevent aspiration. Ketogenic diet is another option in seizure treatment. This is something that can be used in children to control seizures if they're not responding to anticonvulsant therapy. A ketogenic diet consists of a high-fat and low-carb diet that produces a state of ketoacidosis, and they've found that this can reduce the number of convulsive episodes that the child experiences. One other option in the treatment of seizures is the vagus nerve stimulator. This can be used for epilepsy, and what happens is the doctor puts a pacemaker-like device into the patient's body that is meant to stimulate the vagus nerve. The stimulator is programmed to generate small pulses of electricity at regular intervals, and the patient also receives a handheld magnet that they carry with them. They can bring the magnet near the stimulator, and when they do that, it generates an immediate larger current of electricity that can be used to either stop a seizure in progress or at least reduce the severity of a seizure that the patient is experiencing. So again, the stimulator is going to continuously deliver small electrical impulses to minimize seizure activity. But if the patient has a seizure or feels a seizure coming on, they can quickly bring out the magnet to generate a larger electrical current to stop or minimize that seizure as well.